next up, we have Doctors Joanna Jen and Kristin Baranano for our Ask the Experts CACNA 1A related cerebellar ataxia, incoordination, imbalance, and nystagmus. I know this is going to be a very interesting topic. Dr. Jen is a professor of neurology, otolaryngology, I always struggle with that one, and neurosurgery at the Icahn School of Medicine at Mount Sinai in New York. She has formal training in neurootology, the neurology of hearing, balance, and eye movement control. At Mount Sinai, she evaluates and treats patients with dizziness due to a variety of causes, spanning very common disorders to exceptionally rare hereditary neurodegenerative conditions, such as episodic ataxia and pontocerebellar hypoplasia. Dr. Jen's clinical focus is complemented by research performed in her lab on the genetic and physiological basis of disorders affecting balance and eye movement control in neurodevelopment and neurodegeneration. The ultimate goal of her research is to improve diagnosis and develop treatments that will improve patient function and quality of life. She's also a member of the CACNA 1A Foundation Scientific Advisory Board, and we are so grateful for her guidance and unrelenting support. Dr. Baranano is an assistant professor of neurology at Johns Hopkins in Baltimore, Maryland. She's a neurologist with the Ataxia Center and the Kennedy Krieger Institute, and has expertise in the diagnosis and management of children with ataxias and adults with childhood onset of ataxia. She specializes in the genetic basis of neurologic illnesses and has a particular interest in understanding the genetic control of the development of the cerebral cortex and cerebellum. Her clinical interests include whole exome sequencing and child neurology, childhood onset and inherited ataxias, malformations of cortical development, and intractable epilepsy. You were in the company of two of the world's experts on this topic, and this promises to be an extremely interesting hour.
Hi, everyone. I'm Kristin Baranano. Pleasure to be here, and thank you so much for being here today. Today, I'm going to talk a little bit about the background in cerebellar ataxia and CACNA 1A. And so I have no disclosures. And so just to tell you a little bit about what we do at Hopkins and at Kennedy Krieger, we have an ataxia clinic at Hopkins where we primarily see, I see adults with childhood onset ataxia, and then we see the younger children through Kennedy Krieger, which is an affiliated institute for kids with developmental disabilities. And so we're able to put together a wonderful multidisciplinary program there for our youngsters with cerebellar ataxia and cerebellar disorders. So the question is, what is ataxia? So ataxia is decreased coordination of voluntary movements, and it can be very challenging to diagnose in children because this is happening in the setting of developmentally appropriate incoordination. And so where does ataxia come from? It can come from issues with the inner ear in terms of how we understand our position in space. It can come from sensory issues if we're not receiving the right inputs to our brain and brainstem of telling our body where we are in space. And it can come from that structure, the cerebellum, that we're going to be focusing on today in our discussions. The cerebellum itself is this structure at the back of the head, and it doesn't generate motor commands. What it does is it modifies them to make them accurate and adaptive, and it gets inputs from multiple parts of our nervous system through that inner ear apparatus, through these sensory inputs that come up through the spinal cord, and then also the cerebellar cortex and the motor and supplementary cortex through afferents, through inputs that come in through a structure called the pons in the brainstem. And these are just two images of the same patient, an MRI, a sagittal view, meaning cut down the middle. So you can see that structure called the cerebellum at the back of the head. And you can see it's got lots of little wrinkles. And initially in this particular person, it was very plump. But then over a course of a few years and repeated episodes of hemiplegic migraine related to a CACNA 1A variant, we started to see some cerebellar atrophy or volume loss. And so many of your children will have undergone MRIs as part of their diagnostic workup for understanding their neurologic symptoms. And so this is the structure that some of them might have impacted on their imaging studies. So, what does ataxia look like? What are the symptoms that a neurologist is describing when we use these terms? Well, when we talk about gait ataxia, that's when someone is walking with a very wide based, what's sometimes called like a drunken sailor gait, because we know that alcohol affects the cells of the cerebellum in a way that is analogous to some of our genetic disorders that cause ataxia. The term dysmetria means difficulty reaching for items or for feeding herself, which sometimes gets described as a tremor, but it's a little bit different than other kinds of tremor. Dysarthria refers to unclear, poorly articulated speech. And nystagmus is the term we use for a particular kind of jerking or jiggling of eye movements. So when we talk about ataxia, there are lots of different causes of ataxia. And so if a child comes to the emergency department, one of the most common reasons for acute ataxia is actually going to be ingestion of different kinds of medications or substances. Children can have tumors or strokes or demyelinating events like MS or something called ADEM that can cause a relatively acute onset of ataxia. There can be different kinds of infections causing something called cerebellitis and post-inflammatory or post-infectious causes of ataxia. But when we're talking about chronic pediatric ataxia, so children who have a chronic ongoing ataxia, there are three overlapping populations of kids. There are those kids who may have initially had normal developmental milestones and then developed a slowly progressive onset of these kind of incoordination symptoms. There are some children who have episodic exacerbations of their ataxia, like attacks. And there are some kids that we describe as a congenital ataxia, where these are kids who from the get-go have motor problems, and they may initially just be described as having motor delays. And it's only as their motor system develops further along that we start to recognize that there is that significant overlay of incoordination related to cerebellar dysfunction. So when we are initially evaluating causes of ataxia, we're doing a thorough neurologic examination, doing an MRI, lab work, and then oftentimes it requires genetic testing to come up with a more definitive diagnosis for the cause of the ataxia. So many of your children may have had would have had genetic testing to achieve this diagnosis. In many cases, what we call whole exome sequencing. And this is just an example of a result that describes that there's a variant in the CACNA1A gene, the specific spelling change, and that it's a likely pathogenic variant. And so it's important to us as neurologists to understand where in the gene these spelling changes are occurring, because then we can start to make some predictions based on what we know about the different functions of regions of the gene, and also based on other people who've had similar changes. We can start making predictions about what kind of neurologic symptoms someone may be susceptible to having and what their neurologic course may be. So when we talk about the classic CACNA1A associated disorders, there are people who have a familial hemiplegic migraine manifestations, some who have episodic ataxia. And then when there's a completely different kind of spelling change, people are susceptible to something called spinocerebellar ataxia type 6. And that's a very different type of genetic change and different clinical course. With time, we've also increasingly recognized that CACNA1A can be associated with epilepsy and also this kind of congenital ataxia. And I didn't mention it here, but there's also a disorder called paroxysmal tonic upgaze that can be associated with this as well. So in terms of symptoms that oftentimes go along with things like the episodic ataxia, the congenital ataxia, or the hemiplegic migraine, there are a set of symptoms that are very common for kids with different spelling changes in CACNA1A. Many of them will have truncal instability and may be diagnosed with hypotonia or low tone. They may have an unsteady gait. They will have impaired fine motor skills. Sometimes seizures, speech and feeding difficulties are very, very common. Fatigue is a super common issue. And then also attention and mood issues, and then also learning disabilities. And so in terms of managing these symptoms, Dr. Jen is going to talk some about medication, so I'm not going to touch on these here. But the mainstay of managing these symptoms, other than the options for medications, is things like therapies, like physical therapy, occupational therapy, speech therapy. And the idea is that by engaging in these therapies and exercising these neuronal circuits, we can help strengthen the connections and help stabilize and sometimes even improve neurologic symptoms. In a multidisciplinary clinic, we're also going to be looking at things like adaptive equipment that children might need to be able to have their best function possible. This can include things like gait trainers and walkers and AFOs, or even things like assistive technology devices for communication. We also do a lot of neuropsychological testing to really figure out how kids learn best in terms of understanding their strengths and weaknesses and how they learn. And those can then be applied to school accommodations to help kids thrive and do their very best in school. So that's what I have to say in terms of just a little bit of background about ataxia. And I'm going to turn it over to Dr. Jen for her thoughts.
Hello, everybody. It's my privilege to take part in this conference. And I just have a few slides to share with you. This is actually from our campus overlooking Central Park. It's a high-rise jungle. So it's, I just wanted to provide an overview that we're really feeling different parts of the elephant. And so the initial discovery of disease-causing mutations in the CACNA1A gene was made possible by the identification of large families. So again, we're talking about the 1990s, before the genome project, before the first human genome was released in 2000. And so it was a really challenging process of mapping a disease locus to a specific chromosome, and then trying to really fine tune the candidate region, and then go through candidate genes, and then cloning and everything. So it really requires very large pedigrees with multiple affected individuals to help us figure out what is shared among all those who are symptomatic versus what's not shared among all those that are not symptomatic. So, so it was because of the identification of large families with hemiplegic migraine and also other families with episodic ataxia that led to the discovery of mutations in the CACNA1A gene. And so this was in 1996. And so it wasn't until much, much later, as you heard from Dr. Purdue earlier this morning, that, that mutations in this gene were involved in epilepsy, epileptic encephalopathy. So I think that as clinicians and at major medical centers or teaching hospitals, we are all super specialized. And so we all focus on our area of expertise. And so it's not easy for us to actually recognize many other features. So I think that it's been humbling to all of us involved in research in the CACNA1A gene, and that there's so many different manifestations. And so we're really trying to put together a deeper understanding. And so I appreciate the opportunity to communicate with experts from every field to really have a better understanding of the manifestations of mutations in this gene that is widely expressed in the brain, but especially abundantly in the cerebellum. So I think that that also provides some explanation for why we tend to see ataxia in our patients, because the cerebellum is the major center for controlling coordination and everything. So I think that it became clear to us as we looked into the patient's characteristics or clinical features more carefully, that there are definitely overlapping features between episodic ataxia and hemiplegic migraine. And actually, one thing that became obvious early on was that nystagmus, or abnormal eye movement control, was actually a key feature of many patients who were affected with mutations, who actually turned out to have mutations in this gene. And that if you just look at all comers with hemiplegic migraine, it's in the patients who have early manifestation, complicated manifestation with nystagmus that would turn out to have mutations in the CACNA1A gene. So if it's a person with the typical, the usual presentation with hemiplegic migraine, onset in early adulthood, with no underlying, no interictal symptoms, no baseline abnormality, that they tend not to have mutations. And so this is why we actually have a special session today, just focusing on motor control, or ataxia. So ataxia, this term it came from Greek, so it's without order. And Dr. Baranano's already mentioned the core symptoms and signs that involve slurring of speech, clumsiness, gait instability, and also abnormal eye movement. And so here it's just a reiteration that we don't jump to conclusions that, oh, everything is genetic, because there are actually many other conditions many other etiologies that can cause ataxia. And when we focus on hereditary causes or heritable causes, there are also actually an ever-increasing number of conditions that can cause these symptoms. Anything that affect the cerebellum can basically present with such manifestations. So I want to share with you some videos, and so I hope that you can all appreciate this intermittent upgaze in this child. And that was actually the earliest manifestation that compelled this child's parents to seek medical attention. And so here in the center, I hope that you can appreciate that it's actually very difficult for this girl to fixate or to keep her gaze steady. So this is on left gaze, and you can see this jerky eye movement that we call nystagmus, and specifically gaze-evoked nystagmus, so that it beats in the direction of the gaze. And it's not so much when she looked up, but when she looks down, you can also see that it's downbeat. So this is also a very common clinical manifestation in CACNA1A related ataxia. And on the far right of your screen, I hope you can appreciate this patient with downbeat nystagmus. Sorry, the camera was very unstable, but you can see it even more clearly on left gaze. So these are, and all three patients had mutations in the CACNA1A gene. So I want to just quickly go over how we actually got to choose, or we learned to use different medications in CACNA1A related ataxia. There are basically two medications that are in use, and so we're desperately in need of more options. And the first report of an effective treatment, specifically referring to acetazolamide, was actually reported in 1978. And Dr. Birch Briggs, who has been a pioneer and a leader in translational medicine, he led this anecdotal. It was actually a serendipitous discovery. It's a family that had been misdiagnosed, mistaken for psoriatic paralysis, another channelopathy, and they were treated with acetazolamide and had incredible response, amazing response, resolution of their spells. That when it became clear later on that they had actually paroxysmal ataxia that was later named episodic ataxia, that acetazolamide basically became the gold standard. Over the years, so more recently, this is a report coming from Dr. Michael Stroop's group. This was published in 2004, and there's another one that was published in 2007, where 4-aminopyridine was actually used to try to restore or minimize downbeat nystagmus, and also because of the overlapping symptoms of downbeat, which can be localized to the cerebellum, that the same medication was also tried in patients with episodic ataxia type 2 and found to be helpful. So these are the mainstays of treatment in episodic ataxia. So before we open the floor for question and answer, I just want to bring up another, give a shout out to Dr. Cameron Kodaka's lab that has been working on another hypothesis in terms of how mutations and abnormal channel function in this calcium channel in the cerebellum may lead to ataxia. So we've heard a lot about gene regulation and also synaptic transmission and calcium influx. So this is another hypothesis where Dr. Kodaka actually focused on the critically important pacemaking firing of the Purkinje cells in the cerebellum, and noticed and basically established a correlation between the precision in the rhythmic firing of the Purkinje cells with coordination. So these were recordings from, so this is actually a simplified diagram that Tom Botas and I had written in the commentary accompanying a paper published by Dr. Kodaka's group. And so the hypothesis is that the voltage-gated abnormal function of the voltage-gated channels can interfere with the proper activation of a calcium-activated potassium channel that is important in pacing the Purkinje cells. So that the hypothesis was that then maybe if we can actually restore the function of this potassium channel, then we can restore the pacemaking of the Purkinje neurons and therefore restore coordination and balance. And so this is a very simplified summary of the findings from Dr. Kodaka's work. And it is that, so EBIO is a medication that activates the potassium channel. So in a normal animal, there's normal pacing, there's normal calcium influx, and that the medication really doesn't do anything to the normal behaving normal animal. But when this was, the same medication was given to a mutant mouse, and actually this was tested in tottering, in leaner, and also ducky. These are all mutant mouse models that harbor mutations in the mouse CACNA1A gene. What was found was that the firing, the Purkinje neuron firing, was arrhythmic, and so so rather than something that's regularly paced, we have something that's irregular, and that this can actually be restored by medications that can restore the function of, or that can enhance or activate the function of the calcium activated potassium channel. And so since then, Rsoxoxosome, which is another medication that is also an activator of the potassium channel, have been tried in the animal and to demonstrate efficacy. And furthermore, 4-aminopyridine was also tested it doesn't appear to act on the calcium activated potassium channel, but on another group of voltage gated potassium channels that can also restore Purkinje firing. So there are, so we're very fortunate that different research groups are actually trying to figure out different ways of intervening, and so we are very hopeful that we would have more options in terms of treatment and management. So I will end there and open the floor for question and answer.
Rsoxoxosome was demonstrated in a mouse model. Have they ever taken it the next step, or what do you know? Do you know anything about that? Has it gone any further?
So I think that I know that Dr. Stroop in Germany, who has led a lot of the clinical trials, had performed an observational study on, and I want to say that there was some benefit, but I think that we definitely need a more organized trial, a formal trial, to test whether or not this is helpful. I think that different clinicians may have tried just anecdotally different medications. I personally have not had any luck on using chlorzoxazone for treating episodic ataxia, and but I'm definitely open to other observations and perhaps a more organized trial, to other observations and perhaps a more organized trial. Chlorzoxazone for treating episodic ataxia, and but I'm definitely open to other observations and perhaps a more organized trial. Or not, Nanya,
Yes.
Have you tried chlorzoxazone?
We've tried it in a couple of our adult patients and have not been overwhelmed by any perceived benefit in terms of, and these are for patients who have more like spinocerebellar ataxia type presentations, and have not been overwhelmed by really any perceived benefit with it.
Shanna Tolbert has a question.
Okay, thank you, Lisa. Does cerebellar atrophy go hand in hand with progressive ataxia?
Sure. So I can speak to that a little bit. I'm sure Dr. Jen can as well. I know that finding that cerebellar atrophy on MRI can initially be very worrisome to families, meaning that there might be indications that things may progress with time. With our children who we generally predict a relatively stable, non-progressive course, sometimes we can see mild worsening on the MRI that doesn't necessarily go hand in hand with clinical worsening. So I don't think that the presence of cerebellar atrophy is necessarily, a predictive that there's going to be clinical deterioration in many cases. I would defer to Dr. Jen if she had any other thoughts.
So the value of the natural history study and the associated clinical information and possibly some kind of a longitudinal follow-up on imaging, neuroimaging findings would be very valuable. And I think that we desperately need to understand any correlation between patient function and the neuroimaging findings. I think that the consensus is that we're not going to, so that how should I put it? That it's actually very, very important for children and for adults to stay active and to stay physically active and mentally active. It seems to make intuitive sense that the more reserve we have, then the more we may be able to fend off any progressive decline or deconditioning. And and then when the key question, it seems, is that nobody really knows on if there's actually developmental or there hasn't been any strong evidence that there's cerebellar hypoplasia at birth, or there has to be cerebellar degeneration. And from our experience working with adults with episodic ataxia type 2, they're at baseline, the extent of ataxia is actually highly variable, and it seems to be correlated just grossly with appearance on the MRI. But there are patients who have had episodic ataxia for a long time, but don't seem to have any neuroimaging abnormalities. But again, I think that these are all questions that must be addressed using quantitative methods, and not just from me looking at a scan and say, I don't have a feeling that it's, small or whatever. And we have to have data, longitudinal data from the same patients that we can actually track.
And that goes back to filling out our natural history study.
Absolutely.
So Liz Hunter has a question. She wants to know how often you see CACNA1A patients with episodic ataxia type 2 who do not have nystagmus. She says her son has a confirmed mutation and is diagnosed with EA2, but has not ever shown nystagmus in any of his neurological exams.
So I would say that is rare, that's probably not the majority, but that also gives us a lot of insight. The only reason we focus so much on eye movement when we evaluate patients with imbalance or incoordination is that the same center in the brain that controls gait stability and coordination so especially gait stability. So we think of midline cerebellar structures, and that's also where the ocular motor control is. And so we can actually use eye movement as a readout to look at cerebellar function. So I think that so by the same token, there are patients with spinal cerebellar ataxia who have terrible incoordination and some gait instability, but without obvious eye movement abnormalities. So again, we're talking about anatomical localization. And so it is not required. It's just that in terms of circuitry and the expression of the calcium channel, that the cerebellar, so different functions of the cerebellum appear to be commonly affected together. But just because a patient does not have, who does not have nystagmus, certainly doesn't exclude the diagnosis of CACNA1A mutation, as is the case in your child.
He says, apologies for the length of the question. When we initially brought our daughter in for evaluation and she was diagnosed with downbeat nystagmus, we received a differential diagnosis of Joubert syndrome, cerebellar tumor, or oculomotor apraxia. As a result, an MRI was ordered at less than 1 year of age. How do we educate the pediatric ophthalmologic community so that relatively non-invasive genetic testing is done as first-line evaluation as well, or instead of MRIs, for which children have to undergo anesthesia to have it done?
So I think I can speak to this wearing my child neurology hat. And I think the issue here as a child neurologist is we generate the list of possibilities, and we have to prioritize excluding those that are time sensitive. And so, unfortunately, when we talk about the broad range of reasons why kids have abnormal eye movements, brain tumors are on that list. And so, we do have to prioritize making sure we diagnose things like that as quickly and efficiently as possible. And so, however, we try to be very mindful about putting kids under general anesthesia and try to use alternatives. So we're increasingly using ultra-fast MRI as an alternative if we need to just get a quick look overview to make sure that there's not anything like a tumor before we move on. And then there's also the limitation that genetic testing takes weeks to months to come back. And so we understand that it's a lot we put kids through during the diagnostic process and odyssey to figure out what's going on. And we always need to be mindful of what we're asking families to put their kids through.
So one thing that I would like to add to that, I think that I think as clinicians, we're so used to, getting another scan the patient. And if we didn't find it the first time, a few months later, we do it again. And, but I think that now that there is more and more awareness of genetic predispositions, and as genetic testing becomes more and more affordable, that I think that there comes a time when it's going to be part of the routine test. And if we do it right, we only have to do it once, and we don't have to keep doing it. That we can actually just reanalyze the data. So so there comes a time for that. But in your case, I actually would. So I don't want you to feel like the scan was a waste, because even in adult patients, we would also. I think it's actually it's a non-invasive procedure. We do have to rule out structural abnormalities. Maybe not Joubert in adults, but anything in the posterior fossa, we would have to rule out.
Thank you for that explanation. Allison, would you like to ask your question?
Sure, and it's similar to Alok's question, which I think is, my daughter also, one of her first signs was irregular eye movements, and it was an up gaze for her. And we had sort of conflicting answers from ophthalmologists and neuro-ophthalmologists, but it was clear that it was some sort of tracking disorder or something with a neural integrator. So my question is, no one offered us a cause back then. And yes, that was 12 years ago. But I know now that our neuro-ophthalmologist, who's at Children's Hospital in Los Angeles, does have more patients with CACNA1A, but they've all been diagnosed just in the last few years. But the eye movements were one of the things that sort of led them there. So how do we educate even really, optometrists, because that might be the first place someone takes their kid if they're not near a major hospital. But more basically, how do we educate ophthalmologists, neuro-ophthalmologists, developmental optometrists to think about CACNA1A when it comes to eye movement disorders? And don't you think we need to, I guess, is a more basic question.
So actually, I'm drafting a note to Dr. Chung. I was so impressed by the summary of features that she presented, but I would love for her to include in her questionnaire the presence of eye movement abnormalities. So I don't think that this is going to be a biomarker that may change over time. But I think that it would be an important biomarker to recognize as a feature to actually alert the clinicians and the pediatricians to actually consider genetic testing. I will turn over to Dr. Baranano.
Oh, I would certainly agree with that. I think just in general, we are, especially with genetic testing becoming more affordable and more accessible, that barrier of being able to, make people aware of the role of genetic testing and starting to unravel some of these unusual eye movements that are seen in the eye clinic are going to become increasingly, people become increasingly more aware of that as a possibility.
Thank you.
To add to that, there's another question on how do parents and caregivers differentiate pathological nystagmus from epileptic nystagmus?
Sure. So, it really depends on the context. So there's a role here for doing an EEG or an electroencephalogram if someone is having paroxysmal movements that aren't clearly part of an episodic ataxia attack if something doesn't clinically fit. Then, and especially what we're increasingly recognize is the role of epilepsy with CACNA1A variants. So I'd say it really depends on what's going on. If it's just isolated abnormal eye movements, if it really fits with more of like an attack type picture versus, if it's necessary to even monitor to capture brainwaves during an attack to be able to clarify what's going on.
Thank you.
So
Yeah.
I do want to emphasize that the kind of eye movement abnormality that we see in CACNA1A related complications tend to be persistent. It's not, so even for episodic ataxia, it's not like the nystagmus will come and go. It's actually always there, and it may be intensified during an episode. So, so I think that if it's only something that happens intermittently, like paroxysmal tonic upgaze, lasting a few seconds, a few minutes at a time during childhood, that is just one manifestation, but the kind of gaze evoked in nystagmus or downbeat, they don't go away. That has been our experience.
Thank you. I'm going to pivot and ask, there are a couple of questions that have to do more with the neurocognitive piece. One of them is actually about Schmann's syndrome or cerebellar cognitive affective syndrome. Dr. Josh Rotenberg has a question. Josh, do you want to ask your question yourself?
I wanted to, I guess, ask the specialist how you deal with the cognitive and affective aspects that you see developmentally, and what you advise families to do to help with getting educators and everyone to understand that this is more complex than just ADD.
So especially for my work at Kennedy Krieger, which has a lot of different specialists and very good neuropsychology department, we really rely heavily on the input from the neuropsychologists in kind of delineating these issues, as well as if it's necessary, the role of a child psychiatrist in helping address some of these issues. And the neuropsychologists do a really good job interfacing with the schools in terms of helping develop IEPs that are appropriate, and kind of making sure that there's more awareness of these issues as they relate to the ataxia. Any thoughts to add on?
So I remembered one of my first encounters with a patient who later turned out to have to actually have a confirmed mutation in the CACNA1A gene. I remembered that it was very difficult to communicate, or that it took some effort to communicate with the patient, but it was actually relatively easier to communicate with his family members. And I remember thinking to myself that I wonder if it has anything to do with attention or cognitive function. And so I have another item on my wish list for Dr. Chung to consider, and that has to do with if she were to recruit patients who are older, so basically their level of education and profession, something that may give us some other clues or at least evidence. But I tend to, I'm completely in agreement with Dr. Schmann's that there appears to be a cognitive issue that is not the same as other cortical type cognitive problem, and that there may be something specific concerning pathology involving the cerebellum.
Well, Josh actually has another question, which says, how do you ease the discomfort of neurologists in using the term ataxia versus severe developmental coordination disorder?
So I think I found that the converse to be true. I feel that sometimes people are too eager to apply the term ataxia, because sometimes we'll evaluate kids who have been diagnosed with that, and really they're just really on the spectrum of developmental incoordination. And, without necessarily implying that there's something, more deeply pathological than just kids who are on the spectrum of being incoordinated. so I haven't run into that in terms of finding people, hesitant to use the term ataxia.
Lee, would you like to ask your question? Her question is, do the medications presented have an impact on all symptoms of episodic ataxia type 2 or select symptoms?
Very good question. I'm going to give some examples to try to answer that question. So again, going back to my cartoon where, we're just the blind feeling different parts of the elephant. So as a neurologist specializing in dizziness, I tended to see a lot of patients with episodic ataxia type 2, and then realizing that, some of them have complicated migraine, not necessarily hemiplegic migraine or coma, but complicated migraine and that are not responsive to the usual treatment for migraine. And so I think that looking at the different manifestations, so I'm not sure whether you're talking about everything on, that we know, because every patient tends to have, one most prominent symptom and then all the other symptoms. But the thing is, at least from my limited experience treating patients primarily with episodic ataxia, I have seen improvement of their migraine symptoms when we also have better control of episodic ataxia. So in a way, it's satisfying thinking that then the migraine manifestations and episodic ataxia were manifestations of basically the same etiology, and that controlling one helps the other. And so I have also seen patients who responded, actually to my pleasant surprise. Of course, this was a patient without epilepsy who had whose ataxia was controlled by acetazolamide, and yet who had migraine that was still, had some lingering symptoms that were bothersome, and that compelled us to try for immunopyridine. And remarkably, that actually took care of both the episodic ataxia and the migraine. And so that's just, so again, these are anecdotal. And so I'm very eager to see more patients participate in the natural history study so that we can actually have some kind of a tabulation and some correlation regarding the response to medications.
Yeah, and I would say anecdotally with some of my younger patients who are on acetazolamide, families have felt that kids, in terms of their fatigability, has improved in terms of their ability to participate in therapies. And it's something we weren't sure we were really getting benefits, so we tapered it off and then restarted it. And definitely it was a reproducible phenomenon. So there may be some other benefits in terms of other symptoms as well for some people.
Thank you. Interesting. Desiree would like to know, what is the reason for a child to have varying severity of ataxia from episode to episode? And is that common and or expected?
If you can clarify what you mean by more like severity. Is it the duration? Is it the incapacitating symptom? And I just want to have a better understanding.
Okay, maybe hopefully she'll respond to that. But she did ask another question, so maybe we can address this one, which is, if you have a CACNA1A diagnosis, but it's a variant of unknown significance, should you treat it as if it's pathogenic?
So I think that well, my initial reaction is that there's no contraindication for trying. It depends on what goals we have, right? So if I think that we need to be careful of labeling the patient as, definitely having a certain condition without genetic confirmation. But if the patient has symptoms such as episodic ataxia without genetic confirmation, it's perfectly reasonable to use acetazolamide.
Okay, and then there's a question regarding acetazolamide. When you prescribe it, do you tend to suggest that patients take potassium citrate along with it to prevent kidney stones?
I don't, but I do. I do recommend that the patient be well hydrated and you know, have. I think that I advise them to have some citrus every day.
Yeah, we don't routinely recommend that. Just being well hydrated and monitoring renal function periodically.
Back to the question of fluctuating symptoms, this is another piece of the puzzle, right? The mutation is always there. Why do people have intermittent attacks? And so I think that we definitely see varying durations of attack, you know, from attack to attack. And it may take different amounts of time for patients to recover from each attack, but there's usually a pattern and there are usually triggers that can be identified. It's very difficult in infants or toddlers, but the typical, you know, because they can't tell us. But overall, what we see is that sleep deprivation, overexertion, excitement, that these all tend to be common triggers. And so I think that it's not a bad idea to advise every parent and every patient to just make sure that they follow a regular schedule. This is what we tell patients with migraine anyway, that you want to make sure that you sleep well and you have good nutrition with adequate hydration, all the basic things to maintain health, and so that we can actually avoid common triggers for different attacks. Dr. Baranano, I wonder if you have other suggestions.
Yeah, it's the, you know, same question of when someone has a migraine, why is it sometimes a mild headache versus a severe headache with neurologic symptoms? Or if someone has a seizure, why is it sometimes a minor seizure versus going into status epilepticus? I think we don't understand fully what that threshold is for an attack for many different disorders, other than, you know, sometimes the threshold will be really breached for whatever reason, being the number of triggers.
We have a couple of questions regarding gain and loss of function. When we know from the literature, if it, you know, that your variant is definitely a gain or a loss of function, would you treat it differently?
I don't. Unfortunately, when we only have 2 medications to choose from, you know, that are available in the United States, we really don't have a lot of options. And so I would say that I have not. I mean, because it's from yesterday's and today's presentation, I think that we're also understanding that this labeling of gain of function or loss of function, it's not that straightforward. So it's probably an oversimplification also. So the short answer is no. I mean, we just try what tools we have and hope that it would be of benefit. And one more thing is that it's very frustrating. We don't really understand why acetazolamide works.
He asks if there's any interest in publishing a redefinition of the phenotypic presentation of EA2, as it doesn't appear to be nearly as monolithic as depicted in the traditional description. So I know we've asked Dr. Jen to rewrite the chapter in gene cards because she just wrote one on hemiplegic migraines. But why don't you go ahead and answer that question?
So yeah, I think that part of the issue is educating the parents, educating the physicians, educating everybody who's involved in, you know, caring for patients who have mutations in this gene. Yes, we definitely have to be more open and we have to also update the information Again, really, the patients that I saw with episodic ataxia tended to be familial. There were multi-generational, distribution, and it was actually rare for there to be patients who were affected with epilepsy, and yet now with the advent of whole exome sequencing without any prejudice, right? The physicians don't have to know what we're looking for, and we can just order a test and it's going to find variants in whatever gene there may be. And also we don't need multiple individuals in the same family to be similarly affected for us to be able to identify something of interest that we can diagnose de novo mutations, spontaneous mutations. And that's when we're now, presented with this enormous, this new information on manifestations that we didn't used to think as a core feature of CACNA1A related diseases. And so it's been humbling, and we're still learning. And yes, we would do everything that we can to update the information.
Brennan Riley has another question.
Sure. So it's about sort of if a patient has already experienced significant cerebellar atrophy, in a best case scenario for any of these drugs that are addressing motor control issues and lack of speech issues, are those drugs going to be helpful if the patient's already experienced significant cerebellar atrophy? And so I'm talking about like best case scenario drugs, some drug that we think really works. Would it work for that patient who's experienced significant cerebellar atrophy?
I would be hopeful that we have a tremendous amount of reserve in our cerebellum, that even if there's been significant atrophy, it wouldn't make me not try a promising new medication for a child who had significant atrophy.
I would second that. Again, we have no option but to remain hopeful, and we have no option but to, I think that it would be a shame to miss out on an opportunity for potential improvement, for potential benefit.
Louise, would you like to ask your question?
I'd rather you do it.
My son has ataxia and nystagmus, both vertical and horizontal, but the nystagmus seems to occur only as gaze evoked when he has a viral or bacterial infection or a hemiplegic migraine event. Is this in keeping with your findings?
Sure, this is all part of the manifestation, and we do see more more prominent manifestations during attacks, and so if he already has downbeat and horizontal nystagmus in the primary gaze, and actually that's very interesting. So it's already a mix at baseline. There's already evidence of ocular, abnormality in ocular motor control, and so it's still perfectly within the anticipated manifestations. Yes.
In CACNA1A related ataxia and hemiplegic migraines with sleep disorder, which brain structure is afflicted? What medications can you offer for that?
So sleep is one of the most problematic symptoms in general in terms of quality of life, because if your child is not sleeping, you are not sleeping. So that's something we really want to spend a lot of time talking about. We don't understand well enough the systems involved in sleep and how they tie into the cerebellum to be able to pinpoint changes on the MRI related to that. But if you're having sleep issues, you can spend a whole clinic visit talking about sleep. In terms of talking about all the things around sleep, in terms of the sleep environment and all the behavior, things that go into having a restful sleep. Then we talk about the role of a sleep study and making sure that there aren't things that need to be treated, like periodic limb movements or obstructive sleep apnea. And then we do have medications in our toolkit that can help with sleep. They're not specific to ataxia, but can help with sleep initiation and sleep maintenance. So if sleep is an issue for your child, that's something to talk with either your neurologist or get referred to a sleep specialist to talk about in more detail.
So The reason why I chuckled is that it can be a huge problem. And a lot of the patients actually need sleep to alleviate their symptoms from episodic ataxia or migraine, complicated migraine. And so I think that it's not, sleep disturbance is not necessarily a part of the core manifestations of CACNA1A related disorders, but the presence of sleep disturbances can definitely exacerbate and complicate the management of symptoms from CACNA1A related manifestations.
We all know what it's like when we don't get enough sleep.
Absolutely.
Okay, I think I've covered everybody's questions. I'm going back through. If I haven't, if someone wants to quickly raise their hand, if I missed your question, I really do apologize, but in the next couple of seconds, I'm happy to, scan through one more time. Thank you so much. This was really, really helpful, really interesting. And we really appreciate your time answering all of our questions. 3 new messages just came through, but they were all thank yous. So thank you. And everyone appreciates what you just did today for us. So thank you so much.